morning. Today we will have another session. This will be on examination of a case of inguinal scrotal. So we will confine ourselves to the examination of a case of inguinal hernia as well as inguinal scrotal swellings, like most common swelling being hydrocephalic. Okay. We won't discuss in detail about other types of swellings. So what is the definition of hernia? Hernia is a protrusion of whole or part of viscus through the wall through which it contains. Okay. So hernia, by definition, has got certain parts. One is the sac. This is the sac. The covering. For the other cover, sac is usually the peritoneal sac, covering the other tissues, like subcutaneous tissues, skin, everything, fascia, everything, and the contents inside the sac. So these are the three parts of a hernia. The sac again is divided. There are certain parts. That is the neck. The most important part is the neck, the opening into the peritoneal cavity, the body of the sac, and the fundus of the sac. Okay. So most important part being the neck, through which that's the opening through which the contents is protruding out. That's the most important part. Okay. So this is how these are the various parts of a hernia. And inguinal hernia, usually, so inguinal hernia, we have, once we talk about inguinal hernia, what is the opening through which inguinal hernia comes out? So this is a depiction of the deep hernia, inguinal deep ring. This is a superficial inguinal ring. And an indirect hernia will come right through the indirect ring. So deep ring through the superficial ring and present as a hernia. Okay. Whereas a direct inguinal hernia just comes from a defect somewhere here in the medial aspect. So the medially is bound by the rectus fascia, laterally by the inferior bigastric vessels, and below by the inguinal ligament angles. Okay. So this area is called Hasselbalch triangle, through which it comes out, and then comes out through the external ring and comes out like this. Okay. So when you get a swelling in the groin, we have certain questions to get. Whether the swelling is complete, or ask the patient whether the entire swelling is coming right up to the bottom of the scrotum, right from the inguinal region right up to the bottom of the scrotum. It's most likely an indirect sac. Okay. Direct sac usually will be an inguinal swelling. So here three more definitions are required. What is an inguinal swelling? What is an inguinal scrotal swelling? What is a purely scrotal swelling? Okay. Inguinal swelling is some swelling which comes out and remain in the inguinal region here. Doesn't come to the scrotum. Okay. In inguinal scrotal swelling, usually an indirect inguinal hernia comes through the inguinal canal and presents right up to the scrotum. Inguinal scrotal swelling. A third group of swelling is only a scrotal swelling. Here, only in the scrotum. It doesn't extend into the inguinal canal. So those type of swellings, usually the hydrocele and all, that we will discuss a little bit later. Okay. When the swelling is extending right from the inguinal region right up to the bottom of the scrotum, we call it a complete hernia. Okay. It extends from the inguinal region but stops short of the bottom of the scrotum somewhere here. We call it an incomplete inguinal hernia. This type of little bit of explanation is necessary before we go into the. So little bit of anatomical detail. So this is a Hasselbalch triangle. This is a deep ring. This is a superficial ring. So Hasselbalch triangle is an origin of direct hernia. Deep ring is through which the indirect hernia sac come and goes. Because it's going through the deep ring and superficial ring, indirect hernia sac can be complete. Whereas why have you ever thought why a direct hernia is not likely to be a complete hernia? Why doesn't it go down into the bottom of the scrotum? The reason is the posterior wall of the inguinal canal is formed by the transverse fixation. Okay, so direct hernia is coming through a defect in the posterior wall, or weakness in the posterior wall. That is the transverse fixation. So if the hernia bulges out, after a certain limit, the transverse fascia prevents further bulge of the direct hernia. That's why mostly direct hernia will be more of an inguinal swelling. It doesn't extend into the bottom of the scrotum or an incomplete hernia. Okay, whereas indirect hernia, there may be a peritoneal sac. In very young individuals, there may even be a process vaginal. That is only in children. But even in adults, there will be preformed peritoneal sac that will follow the cord structure right up to the bottom of the scrotum. That is why indirect hernia is more likely to be a complete hernia. Okay. With this introduction, we will take the history. Age of the patient. Usually, indirect hernia, there is no age limit in any types of hernia. But indirect hernia and congenital hernia are more common in young and individuals. Direct is usually common in little more older individuals, and direct Can be bilateral because of the muscle weakness also. People who are involved in heavy work and all can be an aggravating factor for the. It's not a causative factor; it's an aggravating factor for a hernia. Already having a hernia, when patient strains more and more, the hernia can come out. So, what are the complaints which the patient presents? Most important complaint is swelling itself. The patient has a swelling in the groin somewhere. Okay, you should ask how did it start, how long it's been having. Okay, so most patients will tell you started slowly and decreasing in size and all those things. And to begin with, you should ask whether the swelling was present right up to the bottom of the scrotum to begin with, or gradually it started in the groin and gradually it extended into the bottom of the scrotum. In the first incident, that is the presence of the hernia in younger age group right up to the bottom of the scrotum is indicative of a congenital sign. Okay. Indirect hernia usually begin in the inguinal region. Slowly it will extend into the bottom of the scrotum. Whereas direct hernia mostly it will remain in the groin only or the inguinal region only. It won't get into the bottom of the scrotum. Okay, is there any change in this swelling on lifting heavy weights or coughing? That means expansile impulse. Indirectly asking about expansile impulse. And also what happens if there is any reducibility? If at all is going in, how does it get reduced? On just by lying down. Here we saw the aspect triangle, the wide opening, whereas in direct hernia is a small, very tight opening. So in direct hernia, just because the opening is wide, on just by lying down, swelling may get reduced. Whereas in indirect hernia, you may have to push a little bit, apply some pressure to get it reduced. So we have taken history about two most important factors about hernia. One is expansile impulse on coughing or straining. Second, to reducibility. So when these two symptoms are present, we can confidently say it's a hernia. Then the next further examination, everything will be only to differentiate what type of hernia. So direct inguinal hernia, indirect inguinal hernia. A third type of hernia we get in this position is a humeral hernia. So we have to differentiate between these two in further sections. Okay. So once we are sure it's a hernia, next set of questions are to ask whether there are any precipitating or aggravating factors. What are the precipitating and aggravating factors? Whatever conditions which increase the intra-abdominal pressure, like a chronic constipation, patient may strain for stool. A urinary obstruction, patient may strain for urine. Then any chronic cough, patient is having bronchitis or anything, patient may cough chronically, produce an increase in abdominal pressure. Patient involved in heavy load working, lifting heavy weights and all these things. Okay, all these things. And very important question also should be asked for this one about smoking. Smoking, just for two reasons by which it can produce hernia or aggravate hernia. One is it can produce chronic cough. Second, it can alter the metabolism of collagen. It can weaken the collagen metabolism. So that the collagen, the fibers which produce strength to the post-abdominal wall can get weakened and can predispose to hernia. So smoking history is also important. So that is about the precipitating factors. Next, if a hernia is there, you should know whether a hernia is simple hernia or complicated hernia. So what are the complications? I'm not going to the theory details here. Complications are reducibility, obstruction, strangulation, incarceration or inflammation. These are the 5 complications. So how will you take the history? You ask about any pain in the hernia. Pain is usually maybe a dragging type of pain patient may complain. That is okay. Some patient, something like a dragging sensation this patient complain. But if it's severe pain, which is associated with the vomiting, distension of abdomen, or discoloration of the skin around on the swelling, all these are very ominous signs of a possible obstruction or strangulation or inflammation. Okay, so this should be asked. Any bilious vomiting is again an important thing with the distension of abdomen is indicative of a intestinal obstruction. Okay, so first you talk about history. Diagnosis of hernia is very simple. The patient may tell you, "I'm got a hernia." Okay, you need to enumerate the causes for any precipitating or aggravating factor, any complications which has developed already in the hernia. Okay, take some past history, like any history suggestive of any history, previous history and surgery for hernia, so that it would be recurrent hernia. Any abdominal surgery is important. Okay, any lower abdominal surgery, because suppose patients having right-sided inguinal hernia. A right-sided appendectomy is very important. We always tell a history of appendectomy. Why is it important? During appendectomy, there is a chance of injuring the ilioinguinal nerve, which is situated between the internal oblique and transversalis abdominis muscle. That is why if you dissect too much between transversalis abdominis and internal oblique during appendectomy, the neurovascular bundle can be injured. So that's why we dissect the internal oblique and transversalis abdominis en bloc. We don't dissect in between. Okay. But once you injure the ilioinguinal, it can weaken the posterior wall of the abdomen. Okay. So that there is again at least a theoretical possibility of increasing or producing a direct type of inguinal hernia on the right side. But right side appendectomy cannot produce a left-sided hernia, remember. Okay. Similar surgery should be done on the left side to produce the weakness. So this past history should be taken. Finally, then you will go into the examination. Okay, so brief history you have taken, all these things we have taken, and also the past history, other medical surgical condition which the patient is having also should be inquired about. General examination is nothing very particular, like in any other case. You should have a general workup for the patient. Generally, hernia patients will be otherwise fit, not very morbid patients, isn't it? Local examination, inspection. We start with inspection. Patient is examined in standing as well as lying position. First in standing position and lying position. Both sides, both groins should be exposed at the same time. On standing position, patient should sit erect. Don't ask patient. Most of the patients have a tendency to see what is happening by bending down, but that is not necessary. Patient should stand relaxed and standing. Then you should make the examination. Okay. You look at the swelling. Usually there will be swelling like this. Isn't it? Either an inguinal swelling or an inguinal-scrotal swelling will be there. You inspect about swelling. Follow the principles of an inspection of a swelling which you have discussed in the previous session. Okay. Like size, position, extent, everything you should know. Here, a direct hernia will be more of an inguinal region swelling. A bulge. You can see a bulge, like a spherical shape swelling in the inguinal region. Whereas the indirect swelling, which is coming through this and producing like this, it will be a fusiform swelling, more of a pyriform shape swelling. Okay, called pyriform shape swelling. So inspection will can give you. Another point is, where is the swelling? So this is a depiction of the anterior abdominal wall. This is the pubic symphysis. This is the pubic tubercle. This is where the femoral hernia. This is where the inguinal hernia will come. This is a deep ring. Okay, deep ring is here. So if you can see, sometimes it's not very difficult to see where it is. Where is the neck? It is not about the whole swelling. Where is the neck of the swelling? Inspection it may be difficult. In palpation it will be more clear. If you can see the neck, where is it situated? Whether it's above the inguinal ligament and medial to pubic tubercle, or below the inguinal ligament and lateral to pubic tubercle. So in this case it will be femoral hernia, this will be the inguinal hernia. Inspection, if you can find it out, is well and good, but sometimes it may be difficult. Any visible peristalsis, look for any visible peristalsis. The large cardiac condition like this, the content is a bowel. You can see sometimes visible peristalsis of this swelling. Color of the skin, whether normal, whether red color, already we discussed about inflammation, obstruction, strangulation, or edema, all these things. Ask the patient to cough. If it's reducible, reduce it and ask the patient to cough. What is happening? Is it coming out? Again, that is indication of an expansion. First, make the patient lie down. Is it reducible by itself? You see, that is indicative of a direct hernia, isn't it? Then also see the position of the penis. If there is a large hernia, the penis can be pushed to the opposite side. Next, you go to palpation. Should be starting with the temperature, tenderness, and all those things. Regarding the size, shape, site, everything should be confirmed by palpation. Okay. Regarding what particular examinations you do for a hernia, that we will see. Okay. Position and extent. That's what I was telling you. So now, palpation is very important. You see the swelling. It is there for swelling. Palpate about the neck of the swelling. If you can reduce swelling and if you feel the neck of the swelling, if it is above the inguinal ligament and medial to pubic tubercle, that is indicative of inguinal hernia. The neck can be palpated lateral to pubic tubercle and below the inguinal ligament is more likely it is a femoral hernia. At this point, you should know what is the femoral hernia anatomy. This is the pubic symphysis. So medial. So what is this? This is the femoral canal. This is a defect through which the femoral hernia comes out like this. So medially this is called lacunar ligament. Laterally is the femoral vein. Anteriorly it will be anteromedially it will be the inguinal ligament, and posteriorly it will be pectineal fissure. Okay. So through this defect it comes out. It's a conical shaped defect. After some time, this face shape is fused with that of the thigh. Then the swelling becomes subcutaneous through the fossa ovalis here, fossa ovalis, or the saphenous opening. It becomes subcutaneous and can present like a torch-shaped swelling like this. It becomes subcutaneous and present like this. So this is why I discussed in the beginning. If you just see a femoral hernia, inspect a femoral hernia, through this it will come. If it is large enough, it may present like this. So it may apparently look like the swelling is presenting above the inguinal. Okay, that is why palpation is very important. Palpation of the neck or the sac is very important. You are determining whether it's femoral or inguinal hernia based on the neck of the hernia, not by the other fundus or body of the hernia side. That part is to be very clear. Okay, so apparently it may look like this, but on palpating you may trace the neck to the below inguinal ligamental and lateral to the pubic tubercle. That means it's a femoral hernia. Okay, that's how you should do. That is the importance of careful palpation. So pubic tubercle, sometimes in thin individuals it will be easy to palpate. Otherwise, what you do, you adductor longus muscle. Adductor longus muscle, how patient to adduct the thigh. Trace adductor longus muscle. Adductor longus is inserted into pubic tubercle. That's how you can determine the position of the pubic tubercle. Okay. Next important thing is, can you get above the swelling? Can you get above the swelling? Suppose the swelling is coming from here, like this. This is a hernia, indirect inguinal hernia. The testis is here. Okay, testis and cord structures are there. Can you get above? What do you mean getting above the swelling? You palpate at the root of the neck, root of the testis, so the scrotum. Are you able to palpate the cord structures separately? Only the cord structures. In hernia, because a lot of hernia contents are remaining, it will be bulky root of the scrotum. You won't be able to palpate the cord structure separately. That means you are not able to get above swelling, because the swelling is obviously coming from the pectoral cavity, isn't it? So you can't get above swelling. In purely scrotal swelling, swelling will be here. So if you palpate here, you can palpate the cord structures there, only the cord structure. That is called the getting above the swelling. That is indicative of a purely scrotal swelling. So inguinal scrotal swelling and guinal swelling, you cannot get above swelling. Scrotal swelling is you can. Consistency, you palpate it, it could be doughy consistency in omentum, gurgling with elastic consistency in case of it, if it's our content is a bowels. Okay. Now, what happens is impulse on cough. Another thing is impulse on cough. You ask the patient to reduce. How will you reduce a hernia? Suppose you are asked what is the best way to reduce a hernia. You can ask the patient to reduce. That's the best way. Okay, patient can reduce. He will have certain techniques, especially if it is a large hernia. Best position is to flex the hip, internal rotate, and adduct thigh. Okay, in that position the abdominal wall muscles are relaxed and hernia can be reduced. Okay, if it is not reduced by patient, cannot be reduced, we can apply gentle pressure on the fundus of the hernia and push it inside. This is called taxis. But taxis you need to be very careful. You cannot just push with a lot of force. It may produce a lot of pain to the patient. Okay. Now, impulse on coughing, how will you check after reducing? One thing, you can put your finger on the external rail and ask the patient to cough. You will feel something is pushing from behind. Or you can hold the root of the scrotum like this after reducing and then ask the patient to cough. You will feel that hernial contents are coming and hitting on your finger. Okay. These are the two methods of seeing the expansion impulse on coughing. Okay. Then there are some after this, you know it's a hernia. Now it's time to differentiate whether it's indirect inguinal hernia, direct inguinal hernia, or femoral hernia. There is a technique described. It is called Siemens technique. Okay. So one finger will be kept here at the deep ring, the index finger. The middle finger will be kept at the superficial inguinal ring, and this finger will be kept at the that is the femoral, and that is the surface of fossa ovalis. Okay. So these three fingers, after reducing the hernia, you keep like this, and patient is asked to cough or strain or blow. That's Siemens described Valsalva's menu. Okay. So what happens? You can see the expansile impulse. If it is on the index finger, you can see it's indirect hernia. If it is the middle finger, you will say that it is maybe direct hernia. If it is here, that is fossa ovalis or saphenous opening, you can say it could be a could be a femoral infarct. Okay. This is how you evaluate. That's called Siemens technique. But before this, swelling should be completely reduced. The reducibility we have already described. The patient asked to reduce. If it's automatically reducing on lying down, more likely it could be a direct hernia. But if there's some force required, it could be an indirect hernia. Okay. How does it get reduced? How does it get reduced? Is it first part, when you push it inside, initial part is going in fast, and later there will be difficulty in reduce. That's typically explained in a momentum as a pattern. Whereas bowel, initial part will be difficult to reduce. Once a small part goes in, the remaining part will go in with a gurgling sound. That is commonly described in a bowel as a content. So here we can distinguish between the contents also. Okay, so contents by reducing how it is getting reduced and all these things. Okay. Next test is an imagination test. We don't usually advise students to do this test because it's a little painful test. The scrotum is imaginated either with a small hand finger or with index finger. Get into this, palpate the deep ring, superficial ring here. Usually it will be triangular shape, slightly fitting the tip of your finger, and ask the patient to strain. You can feel the external ring, the superficial ring is squeezing onto your finger. If it is patellus, means it's a little abnormal. Then after entry, you keep the finger like this in the direction of the lingual canal, so that the tip is facing the deep ring and pulp is facing the posterior wall. Ask the patient to cough. Because the indirect lingual hernia comes through the deep ring, it will come and hit your tip of the finger. If it pulse is felt on the tip of the finger, it is most likely indirect, or if it felt on the pulp and it was the palm side, it is more likely to be direct side. But it's a test I would advise you to do very often because it is a painful test for the patient. Next is ring occlusion test. This we can do. Ring occlusion test we can do. So we have described it here. This is the deep ring. This is lateral back triangle. So deep ring corresponds to the mid-inguinal point. That's the pubic symphysis, and will expand midpoint, maybe half a inch above. Okay. So this hernia is reduced, and you occlude the deep ring by anatomical landmarks and ask the patient to cough again. Because we are occluding the deep ring, if it's an indirect hernia, it will not come out unless the deep ring is very patellus. There is one exception. When very patellus deep ring, still indirect lingual hernia can come out. But that's the difference. Don't pay much attention. But there is somebody asks you, there's an exception. But direct hernia, because it's coming through a medial defect, not through the deep ring, you can observe as a defect or hernia coming out medial to your occluding finger. That indicates that it could be a direct lingual hernia. Okay. So this ring occlusion test is differentiate between direct from indirect. Right? Deep occlusion ring differentiate from direct inguinal hernia from indirect inguinal hernia. Now, after this palpation, you have done your tests. Whether it's inguinal hernia, you know by seeing where is the neck of the side. Whether it's indirect inguinal hernia, direct inguinal hernia, or femoral hernia, you've done Siemens test. If it's inguinal hernia, you have differentiated by doing the test, the ring occlusion test between indirect and direct hernia. By this time, you know what is the diagnosis. This is it. Whether femoral hernia, indirect inguinal hernia, direct inguinal hernia. Okay. Now, even you can percuss, it's not very important. Percuss, even if it's bowel, you may get some resonance. There are some stamps, and the auscultation also is not very important. Should examine the testis and the now here at this point, you should see the abdomen. Okay, after in the hernia examination is not complete without examining the abdomen. What will you see in the abdomen? What are the examinations you do in the abdomen? You should see the tone of the muscle. Okay, but some people will have very flabby abdominal wall. They are more prone for a hernia. What is Malgain's bulge? It's due to. So ask the patient to raise their head after putting the patient supine. You will see some supra just above the inguinal ligament, in medial half of the medial inguinal ligament, some bulgings. It's due to the weakness of the muscle. Okay, so that is indicative of weak tone of the abdominal wall muscle. That's one, tone of the abdominal wall muscle. Any scar, which we have described before, any scar in the abdominal wall in the lateral part, you should see. Palpate the abdomen, any mass, any ascites which will increase, or any malignancy is one important thing. A recent onset hernia in a middle-aged old man, you should always think about intra-abdominal malignancy. So palpate for any mass in the abdomen, ascites, abdominal wall, tone of the abdominal wall, and the scars in the abdomen. Also in the male, always try to do a parental examination, because prostatic enlargement may be there, which may be again a precipitating factor for the hernia. Okay. At this point, I will describe now. This is about an inguinal scrotal swelling, especially a hernia. Now, suppose this is only scrotal swelling. What are the three most important scrotal swellings you usually come across? One is the hydrocele, the other one is the spermatocele, the other one is the epididymal cyst. Rarely testicular tumors. We are not talking much about testicular tumors at this point. These three types. It's mainly hydrocele. So hydrocele and hernia, as a student, you will have to distinguish between hydrocele and hernia. If you have listened to my class till now, you will be able to tell the difference between a hydrocele and a hernia. Hydrocele is nothing but what is the commonest type of hydrocele you see in adults? It's called vaginal hydrocele. That is so this is the scrotum, this is the testis, this is the tunica vaginalis. So a fluid collection in the tunica vaginalis is called vaginal hydrocele. That is the most common type of hydrocele get in adults. Okay. So how to distinguish between? I will be giving the difference between vaginal hydrocele and inguinal scrotal swelling. How will you distinguish? So hydrocele will be on inspection. What will be the thing? Swelling will be the scrotum. It will not be inguinal scrotal swelling. Possibly will be able to see the upper border. And impulse on cough. There will be no impulse on coughing. It won't be reducible. You ask the patient to lie down and ask the history. This won't be reducible. Okay. On palpation again, it will be purely scrotal swelling. You can get a border swelling. Okay. If you palpate here at the root of the swelling, at the root of the scrotum, you can palpate the upper border. Ask the patient to cough. There will be no impulse on coughing because it is situated in the scrotum only. Right. So there will be no impulse on coughing, no reducibility. You can get about the swelling. And if you palpate for the testis, what happens in the hernia? I depicted here. The hernia will be like this, testis is like this. Usually you will be able to palpate the hernia separately. Even if it's a very large hernial sac, testis will be separately palpable. Because hernia almost never engulfs the testis. Suppose it's a testis, hernia will come and touch or adhere to the testis, but testis will be, careful palpation will be separately palpable. But in this situation, because the fluid is around the testis, vaginal hydrocele, testis, especially in a large hydrocele, this testis may not be separately palpable. But in a small lax testis hydrocele, maybe you will be able to palpate, but that too only through the fluid. That is again one test. Then two other tests like the fluctuation. Because hydrocele is fluid, you will be able to see the fluctuation. How you do? The root of the testis is held like this. Here you can hold. You can either squeeze with these two. So these two fingers are also stabilizing the swelling in the exam. And when I told you about the examination of swelling and described all this, you have to stabilize the swelling, then squeeze. Either you can squeeze with these two fingers and feel with these two fingers, or what you can stabilize like this. With this finger you can press here, keep another finger here, you can palpate with the other finger, so that you will see the fluid displacing or raising the other finger. So it's called the fluctuation. Next test is transillumination. That is, two things should be satisfied to get transillumination. Three things. One is to be cystic swelling, the fluid should be clear, and cyst wall should be thin or translucent. Then only you will get transillumination. What you do? So put a torch here. You can use some dark tube to visualize the transillumination. Put a torch here and see whether the whole swelling is getting transilluminated. One mistake you do here is you put the torch on one end and you put the transilluminated scope on the diametrically opposite position. That is not acceptable because the testis will come in between, so you may not get the transillumination as possible. Okay, should be always tangential. So light from here, you visualize tangential. Okay, so transillumination. So I told you it won't be reducible. There will be no impulse on coughing. You can get about the swelling, and testis in her hydrocele will not be separately palpable. Okay. So this is again very important thing to distinguish. Sometimes this hydrocele will be very large, it may extend right up to the superficial inguinal ring. Okay, sometimes it will be difficult. So, but still with careful palpation, can palpate the upper part of the skull. Okay, upper part of the you can get above the skull. Alright. Now, I will also distinguish how you distinguish between a epididymal cyst and hydrocele. Sometimes a large epididymal cyst will look like a hydrocele, but on careful palpation, you will see the testis and the epididymal cyst are separated. Testis can be separately palpable because the cyst is arising from the epididymis. It is not engulfing the testis. So it will be fluid, it will be transluminant, it will be fluctuant. You can get above the swelling. It won't be reducible. All these features will be there. So there is a tendency easily you will diagnose it as a hydrocele. But one thing will be distinguished. That is it is just stuck to the testis. It is not engulfing the testis. So the testis will be separately palpable in a epididymal cyst. So don't make the mistake of diagnosing any cystic swelling in the scrotum as hydrocele. It could be epididymal cyst. It will be brilliantly transluminant. All the features of a hydrocele will be there, but testis can be separately palpable. Okay. I think that's how you should approach a case of inguinal-scrotal and scrotal swelling. Okay. If you remember these points, you will be able to tell first whether it's a scrotal, inguinal, or inguinal-scrotal swelling. If it's scrotal swelling, whether it's a hydrocele or whatever, so many other differential diagnoses are there which you have to read out. I don't have time to discuss every. Most common conditions are hydrocele and epididymal cyst. If it's inguinal-scrotal swelling, you need to distinguish. Is a hernia, which type of hernia? It's a direct hernia, indirect hernia, or it's a femoral hernia. Okay, so depending on all these features, you should do. Okay, finally you should come up with how will you write a diagnosis of hernia? Right-sided, direct or indirect, complete or incomplete, complicated or uncomplicated, inguinal hernia, or femoral whatever. That's how you should write. Okay, final diagnosis. And that's it. Okay, or hydrocele, right-sided, vaginal hydrocele. Okay. I hope it was useful for you.